Okay, so thank you again for coming tonight. We are very fortunate to have Diane work back with us this evening. This is her, gosh, I think your third time this year, isn't it, Diane, joining us?
It is.
And everybody loved you, and we're thrilled to have you back. Tonight, we're going to be talking about navigating life after a blood clot diagnosis. So many of us did actually not get much of an explanation about what had happened to us. I'm still learning 7 years after the fact. So was Todd. And so you're going to enlighten all of us about all things blood clot related after a diagnosis. We want to remind everybody that we are not here to give medical advice. This is for educational purposes only. Please do speak with your own clinician. Everybody is different and unique, and you really need to have a one-on-one conversation with your doctor. But this hopefully will give you some additional information to speak to them about. So I know Diane has been here before, but just for those of you who are new this evening, just so you all know that Diane is truly recognized by her peers as an expert in all things VT, but in particular anticoagulation management of patients. She was previously employed at Grady Memorial Hospital, where she managed the Department of Cardiology and Anticoagulation Clinic, as well as provided clinical support to the department. Diane was managing or was instrumental in establishing the heart failure program as well. And she spent the first 17 years of her career at Emory Healthcare. I thought you were 35. The last year, a few years in which she managed the 8 anticoagulation clinics with 3,000 plus patients. Some night I'd like to hear how you did that. And established a large virtual clinic with over 300 patients trained to self-test their INRs at home. Amazing. She was appointed to the Anticoagulation Board of Directors in 2013 as a certified anticoagulation provider. And she has been an integral team member in a joint venture between the CDC and the National Blood Clot Alliance to develop educational curriculum for thrombosis. She has published articles on genetic mutations while at Emory Healthcare. And her research interests include anticoagulation, obviously, I think we figured that out now, patient education and reduction of hospital admissions. I really wish that I had met you the day that I was diagnosed. But with that, before we move forward, we're going to kick it back to Todd so that he can read off some poll questions for us. Todd?
Great. And I know you don't know about my technical issues, but I've actually had a few that I'm trying to walk around. Love-hate relationship with technology, I'm telling you. It's just...
Tonight I'm in hate mode.
Me too. So I'm just hoping everything goes smooth here. Okay, great. We've got the poll questions up. Here you go, folks. How long ago was your blood clot diagnosis? Less than a month, 1 to 2 months, 3 to 6 months, 6 to 12 months, or over a year, or not applicable? If you could answer that, great. Our second question, were you satisfied with how your medical team explained your condition upon diagnosis? Yes, no, or not applicable. Who conducted this conversation with you about your diagnosis? Was it your doctor, your nurse, a physician assistant? No one had this conversation with me. If you could choose one of those. We have 2 more questions. Number 4, were you satisfied with how your medical team explained your anticoagulant medication with you, including any associated risks? Yes or no? And who conducted this conversation with you about your anticoagulant? A doctor, a nurse, a pharmacist? No one had this conversation with me. If you guys could answer that, we're going to pull up the answers real quick, and then I'm going to kick it back to Leslie. Okay, let me roll back up to the top here. How long ago was your blood clot diagnosis? 14% said less than a month. 14% said 1 to 2 months. 20% 3 to 6 months. 10% 6 months to a year. And over 12 months ago, 37%, 5% not applicable. Were you satisfied with how your medical team explained your condition upon diagnosis? 32% said yes, but 59% said no. Who conducted this conversation with you about your diagnosis? 52% said doctor, 12% nurse, 15% had a physician assistant had this conversation, 18% no one had this conversation with me. Were you satisfied with how your medical team explained your anticoagulant medication with you, including any associated risk? 52% said yes, 45% said no. Last question and results. Who conducted this conversation with you about your anticoagulant? 52% said doctor. For nurse, it was 15%. For pharmacist, 9%. And 21% said no one had this conversation with me, Leslie. And that's a little disturbing.
Yes, very disturbing. I agree with you. Okay, so just want to remind everybody that we're going to save some time at the end because we had a lot of questions come in from folks before tonight. But we also want you to put your questions in here for us as well, for Diane to answer. So if you're listening in, you have a question, please put it in the chat function as well. Okay, so let's start out with understanding the diagnosis. As we said before, that many of us actually didn't get much of an explanation after our diagnosis, and some of us really didn't get any explanation about our diagnosis. So let's take it back to basics. So first of all, what is a blood clot? And frankly, what does it look like? What's the difference between DVT and PE? And also talk to us about why it matters if a clot is provoked or unprovoked. And I'm hoping that my teammate who is on tonight can actually bring up some pictures for us.
Great, there we go. So everybody that is on this webinar is here to learn about clots. And we're going to talk about the two types of clots that we commonly see come in through typically the emergency room, or sometimes they may go to their primary care. And a blood clot is just a clump of cells that come together to plug something or to block blood flow. And they're not all bad, because when you cut yourself, you form a scab, and a scab is an example of a blood clot. When it becomes problematic is when it happens inside a vessel and it's not for a good reason. Sometimes we need our body to make clots. You have red blood cells, you have white blood cells, you have clotting factors, you have platelets that when it's triggered, they migrate to the site where either a cut is or where this clot is forming, and it gets big enough to form either a problem if it's inside the vessel and it's not stopping you to bleed, or it stops the bleeding. On the left side, you can see here, you've got blood clots that are in the veins. You can have blood clots in both arteries and veins. We're going to focus on veins right now. These are deep vein thromboses. And you can see the left side is bilateral. So that's coming up typically from the left side. You can see the veins in the proximal leg where they're coming together. They merge there in the middle, and then that's going up into the inferior vena cava and up further. This can become extremely problematic because it's impeding the blood flow back to your heart when the vena cava gets clogged, and you can migrate into the organs that come off of there and have all sorts of organ damage. Typically, we don't see this extensive amount of clot. This is pretty extensive here, especially bilaterally. Typically, most people will present with one clot, not in both legs. I'm always suspect when a patient comes in with clots in both legs, especially if it's unprovoked. Is there an underlying reason why they're clotting? And we'll talk about that later, about some of the risk factors. On the right, you've got a set of lungs there, and you can see how the branches, it looks like a tree. So we call it the pulmonary bed or pulmonary tree. And if any of you have had a saddle pulmonary emboli, right there in the middle is where you would see a big clot that goes to both sides. The clots can go down into the smaller vessels and they're not as problematic, but the ones that people present with, that about 30% of patients that have pulmonary embolism present, and it's because they've had an arrest. They've died, and it's because they've had one of these big clots. When it clogs all these bronchioles up, the blood vessels there can't produce oxygen to the alveoli, and so there's no oxygen for your tissues, so you will have a cardiac arrest because of this pulmonary embolism. So that's essential, the difference between them. The pulmonary embolisms are in the lungs, hence they're pulmonary, and the deep vein thrombosis can happen anywhere in your veins. Typically, what we see most often is in the legs. Occasionally, we may see them in the upper extremities, the arms, if they've had clots in their arms, or if they've had catheters or PICC lines or ports. And then you can always have weird clots too. You can get them in your liver. You can get them in the portal vein. Some patients may present with a clot inside their heart.
Okay. So DVT typically in the leg, but can present in the arms and occasionally elsewhere. And then the PE is what goes into the lungs. Just a question on the two. Is the PE always a result of DVT, or can it actually present itself by itself?
It can present by itself. Oftentimes, the patient will have had a history of some pain or swelling in the leg, and the entire clot moves. A pulmonary embolism meaning that it's moved. But there has been cases where patients, the only place that we have any evidence is that they're in the lungs. It's rare, but typically it's moved from somewhere. The
Okay.
other place I didn't mention that we see is venous sinus thrombosis, which is in the brain.
Yeah. Okay. And then just let's circle back to the provoked versus unprovoked.
So the provoked are a little bit more problematic because we don't know what triggered the clot to happen. There wasn't any trauma, there wasn't surgeries, there's not a known thrombophilia, they don't have an active malignancy. And so the question is, why did they clot? I've been doing anticoagulation for a long time, and right before I started was when factor V was discovered in the 10 years prior to that. So I am of the school of thought that there's probably other things out there that we haven't discovered that are making people clot. So just because you have an unprovoked clot doesn't mean if they can't find anything, it's safe for you to come off anticoagulation.
Yeah.
And
Which is
then
really,
the last
it's really
question
important
was,
for people.
yeah, what was that last one? There was one more. The difference between, the provoked clot are going to be more your catheter, like if you've had an IV in or a port, you've had surgery, you've had trauma, prolonged bed rest, maybe long car rides, immobility, those types of things, because you have pooling of the clotting factors when you're not moving around. So those are more provoked. We used to think that if it was a provoked clot and you do your treatment and you come off, you're fine. But what we've learned over the last 15 or 20 years is that once you've clotted, the risk does not go back to pre-clot if it was a provoked. So you're always going to be at risk for having another event higher than what it was before you had your first clot.
Is there any data around what that higher rate is?
I did a little bit of research today, and I would say it's about 4% is what I read in the literature for people that have had provoked clots, that it never totally goes back to like 1 to 3, which is what the average population is.
Okay, that's really interesting. Okay, so we know what the clot is, we know what DVT and PE are, and now we know what the difference is between provoked or unprovoked. I can tell you that until I met NBC, I didn't know what the difference was between the two of them. So it's really important because it influences how you're going to get treated.
Especially the duration of therapy, it does.
Okay, thank you. Todd?
Yeah, and Leslie, can we just remind everybody to put their questions in the Q&A instead of in the chat? There's a lot going on in the chat. Sometimes I don't go through the chat, but I think we're supposed to use the Q&A for the questions instead of putting them in the chat. Makes it a little easier. Let's move to anticoagulation. After diagnosis, most patients are prescribed a blood thinner, or more accurately, an anticoagulant. Four-part question for you. How do anticoagulants work? How do clinicians decide which one to prescribe? Because we have, warfarin, we have DOACs, and how often should it be taken? Why is it so important to take them consistently? And what are the risks of being on an anticoagulant? And can someone stay on one of those long-term, like for life?
Okay, let's break it down. And the first question was,
how do anticoagulants work?
Okay, so they do not dissolve the blood clots. what they do is they slow the clotting cascade down. So you have a cascade of events that happens to form a clot. And they work on different parts of that clotting cascade. Warfarin, which has been around for now 75 years, works on clotting factors 2, 7, 9, 2, 5, 7, and 9. The DOACs work on factor 10A, activated factor 10A. Dabigatran, which isn't widely used, works, it prevents thrombin from being formed. So it doesn't directly affect the clotting cascade, but how they work is it slows the clot from forming. So when we talk about warfarin, those clotting factors that affect warfarin are vitamin K dependent. That's why diet is so important, consistency. The second part of the question was, how does a provider pick which one, correct?
Correct.
So we have our favorites, I guess. We have what we get comfortable with. For a long time, the only thing I had in my tool bag was warfarin and low molecular weight heparin, or unfractionated heparin. And then around 2011 is when the DOACs, the direct oral anticoagulants, came into play. And there are a couple things that affect our choice. So is the patient a once a day or a twice a day person? Are they going to remember to take a pill twice a day to stay safe? Or are they someone that can only remember to take medicine once a day? I have done heart failure for a long time in cardiology, and I always try and put my patients on once a day meds, because if they forget, chances are if they use a pill box later in the day, they'll say, oh, I forgot my pills, but what I have found, the other thing that I found with twice a day anticoagulants is patients try and stretch them out. They think, oh, I'm taking one, I won't have to do that second copay. I'll make it last 2 months. And that isn't how these drugs work. It's important to take them as prescribed. And I tell providers when I educate them to prescribe them the way they're meant to be taken. So I know this is on DVTs, but we may have other patients that are on for other reasons that are listening. But you should take it the dose that's recommended for the treatment of what you're trying to prevent or treat. So with the direct oral anticoagulants, those typically have a lead-in time. The first week to 3 weeks, you're on a different dose before you go on a maintenance dose. And it goes by, it's decided by the clinical trials that were done. So with apixaban, you take a bigger dose for the first week. With Xarelto, you take a larger dose for the first 3 weeks. Dabigatran usually requires a lead-in with a low molecular weight heparin before you start. So it's just a preference by the provider, as well as what the patient's labs look like. So if you have a renal problem, that may not be the best one for you to take if you're on dabigatran. It may be better for you to be on warfarin if you are on dialysis than going on apixaban or Xarelto, which are the two that are most widely prescribed for VTE. So it just really looks at the labs. And then the last question, I think, was, can you take it lifelong? Yes, you can be on it for life. It needs to be evaluated at least every 6 to 12 months by a provider to make sure it's still safe for you to take. So you need to have your labs checked to make sure you're not having a slow leak anywhere. Your CBC or your hemoglobin can drift down if you're having a GI bleed, if it's just a slow one, or if your platelets go out of whack, you don't want to not have any platelets because you need those to still clot. So those are some of the things we look at. And then looking at the renal function to make sure that the renal function has remained steady so that you don't need to be switched to an alternate if your kidneys are failing.
What are some of the
cleared renally?
Okay, so what are some of the risks in taking an anticoagulant?
The biggest one is bleeding. That's going to be the biggest one. I can't say that I've seen anything. No disease states are being caused, no cancers or things like that. I haven't seen any of that pop up in the last 20 years saying that. they're the biggest risk probably for any of the anticoagulants is if you take them while you're pregnant, they can affect the fetus. That would be the one thing that it's a risk for. So you need to make sure that you're monitoring yourself, and if you're trying to get pregnant, to have that discussion with your provider to get on a parental or an injectable to protect you as well as the fetus. So we know that damage to the fetus can be done if you take any of them at different stages of the pregnancy.
And people may bruise more easily
Yeah,
on
bleeding.
anticoagulant, correct?
Yeah, and that's expected. What you want to do is if you have a bruise, I always had my patients, if it was a big bruise, especially if it was unprovoked, if you didn't bump yourself and you start bruising, then you need to get in. And that used to be a bigger deal when they were on warfarin. We saw it a lot more on warfarin when their INR would go out of whack. They would all of a sudden start bruising. But to mark it, take a pen, mark it, and see if it gets bigger. It's going to spread out a little bit, but we worry more if it gets higher. So if it raises and it becomes firm or hard, you're bleeding under the skin.
Yeah. And so I moved from a once a day to twice a day. So from Xarelto to Eliquis. And I had that concern, oh, I'm going to have to take 2 doses a day. I thought it was going to be a pain. But it's funny how you take it seriously and you really do focus on taking it twice a day because it's better than suffering another abnormal blood clot, right?
And it's not a big deal for a lot of patients that already take twice a day meds.
Right, right.
So, I mean, a lot of our patients, if they're on meds that they take twice a day, it's not a big deal. But for those that only take once a day meds and then you add a twice a day med, it can be more, I use both. I use both apixaban and Xarelto. So it's patient preference.
Thank you. Okay, Leslie?
I have two follow-up questions on this. So for those of us that take the DOAC, let's say you take it at 10 o'clock at night. When does it become effective? Like how long does it take for it to kick in? Is there a period of time when it's the most effective? And then does it start to wind down? Or how does the actual process of it work?
So the half-life of the drugs are different. Xarelto's half-life for someone that is under 45 is 9 to 11 hours, and apixaban is a little bit shorter. That's why it's twice a day. And the peak time will be about 2 hours after each dose. So if you take your Xarelto, it peaks in about 2 hours and then starts to trickle down. The same with the apixaban, it peaks, trickles down. You take the second dose, it peaks and trickles down. That's why it's important that you take these medications around the same time that you normally would every day, because they're very quick on and very quick off. So if you miss a dose of your Xarelto, you are not protected one day later. Where warfarin, patients would miss dosage frequently, but because their INR takes a little while to drift down, you wouldn't see it as much. But with the DOACs, it's very important that you take the Xarelto every single day and the apixaban twice a day.
Okay, thank you for that. There's been some companies lately that have been marketing, find out when you're at peak anticoagulation, which kind of sounds like BS, but I don't know if it is BS or not.
So you have to have special instrumentation to do the levels of the drug. We can monitor and say yes or no. There's levels on. I work at a trauma center. Grady's still is a trauma center, so and it's a sophisticated lab. It's not every lab that you can go to, and so to go to LabCorp, they're not going to be able to do that. You have to have a special reagent to do that. So we do not encourage checking levels or heparin assay levels, anti-10A levels when you're on the DOACs, because it does require special instrumentation to do that.
Okay.
And it doesn't necessarily mean anything. The same as if if you have someone that is on a DOAC and they draw an INR on it, the interns, especially in July when they're new, freak out because they'll see the patients on an anticoagulant and they'll think, oh, I remember medical school, we check INRs for this. I don't see it as much now as I did, a couple years ago, but it affects the INR, but it doesn't affect it the way Coumadin does or warfarin does. So I've had people with INRs of 7 and 8, which is really high, on the DOAC, on Xarelto, and it means nothing. So just be careful with You don't need any special lab monitoring when you're on those other than checking your renal function and your CBC.
Okay. And does weight play a role with the DOACs?
I would say no. I have not seen that. I've used safely both apixaban and Xarelto in the morbidly obese people that are 400 pounds at the regular dose, and I have never had an event. So there's been adequate studies in looking in the obese and the morbidly obese that these drugs are safe to take.
Okay, that's important to know. Okay, so let's talk about monitoring your blood. So we've had our blood clot, and now they're like, okay, we're going to do a whole bunch of blood work on you after the clot. A lot of us don't understand what's actually happening, other than the fact that we're giving a lot of blood to be analyzed. I was like, my God, how much blood do I actually have? You've taken most of it out of me, I think. So what are the labs that get commonly checked? I know there's INR, there's D-dimer, there's labs that get done when you're being diagnosed, and then there's labs that are done after diagnosis. And so what do they all do? What are they all for?
So in the beginning, when you first go in, the D-dimer is a byproduct of clot. So I kind of describe you have like little Miss Pac-Mans going around trying to chew up clot in your blood all the time. That's your protein C's and your protein S's, and they're chewing those clots up so that they don't become problematic. That's what gets rid of a scab went from the inside. They're working to try and get rid of the scab, chewing the blood clot up. Well, when they break that clot up, the byproduct is the D-dimer, and that's always going to be present in your blood. You're always going to have some D-dimer because you're always making clot and always dissolving clot. It's never, but there's a balance. When it becomes out of balance, then we see a rise in the D-dimer. That's probably the most basic one, that if you come in with shortness of breath, chest pain, swollen unilateral leg that is, that looks like, oh yeah, this person might have a clot, they'll draw a D-dimer just to see if it's elevated. And
Okay.
if it's elevated, sometimes there's a decision tree that we use that will say, okay, let's get an ultrasound or let's get a CT, or, if the patient's unstable, they may take them and do an angiogram to see if that's the gold standard, is to do an angiogram if you're looking for a massive PE. But that's rarely done. It's usually a CT PE or a VQ scan. They look for the CBC and the platelets, because if we're going to give you an anticoagulant, we need to make sure that you have enough hemoglobin and blood cells so that if you have a bleed, you're not going to die from bleeding. We don't want to create anything more. And we want to make sure your platelets are okay so that you can still clot if you need to. And then the other one would be the renal function, would be the other basic one that we would do. A lot of times a prothrombin time and a APTT will be done, or a PTT, just to get a baseline before anticoagulation is given. The APTT is important for patients if you think they may have a lupus anticoagulant, because oftentimes that's elevated and that can skew the INR then. So they do basic labs before they start anything, so they have something to work off of. The thrombophilia testing, I don't encourage that to be done around the time of the clot. That can be done at a later time. It's not going to change what you're going to do to treat the clot. If you're factor V Leiden, if you're prothrombin gene mutation, if you're protein C, protein S, especially don't check around the time of a clot for that, because those numbers are going to be very skewed because they're working to try and dissolve the clot, the protein Cs and protein S's. Antiphospholipid antibody syndrome, those can be tested initially, especially if it's someone that's had recurrent fetal loss or someone that presents with a stroke, because those tend to be more of the APS patients that we see. But that needs to be repeated in 6 weeks. So hematologists typically do not test around the clot time. They wait till things cool off. And then if there's a good reason to check for thrombophilia, they will.
And do you have to come off of your anticoagulant for any of those tests?
Yes, some of them you do. And then you usually go on to a parental, you go on low molecular weight heparin, and those labs are drawn. And it can get a little dicey if they're thinking you have an antithrombin deficiency, then that can get a little dicey. So that's why if go to a hematologist and let them decide if they want to test for clotting disorders. And I know there were some questions that came through about family members testing, and that I do not encourage family member testing unless the patient has a homozygous, where they've gotten a gene from both parents and they're much higher risk for having a clot. So then you may want to, that doesn't mean you're going to necessarily treat them, family members, with anticoagulant, but they need to be much more careful than if they were, if they didn't. So
Sure.
homozygous, or then there's just some, like if it's an antithrombin deficiency, then we might encourage other family members to get tested.
Okay. It's really interesting. I mean, Todd, you in particular, but it hasn't really been that long since factor V Leiden was discovered.
Mm-mm.
1993, was it?
Yep.
Amazing how
Yep.
many people have this, and it hasn't been that long ago since it was discovered.
No, and 5% of the Caucasian population is factor V Leiden positive.
Yeah.
So there's a lot of people around, but it doesn't cause clot in 5% of the population.
Right. Wow.
When my mother died sudden death when I was a kid, factor V Leiden hadn't been discovered yet,
Yeah.
and I couldn't connect the dots until later on, and then found out I inherited it from both parents, which explains everything, which kind of moves us in the direction that I wanted to go with you. Talking about reoccurrence. So I've had 7 blood clots. I may have an 8th at some point. At this point, I'm kind of used to it. I'll deal with it if it happens. But let's talk about reoccurrence, because in the support group, a lot of the patients, that's like their number one anxiety fueled issue is, am I going to suffer another blood clot? So my question to you is, can this happen again after your first blood clot? Why is the risk higher in the first 30 days, like that first month after the blood clot? And what's the long-term risk of a second blood clot?
Okay, so 0 to 30 days, that clot is not stable yet. So you want your Miss Pac-Mans to come around and chew up as much of that clot as it can. And you're going to take your anticoagulant so that clot doesn't get any bigger. While the protein Cs and protein S's are dissolving the clot, you will endothelialize around it. So you'll start to form a mesh around it to stabilize it so it can't move. So it's during those first 30 days that you're at risk for an embolism. So if it's in the deep veins of your legs, you're worried about it moving to your lung and blocking a major blood vessel and death. Day 30 to 60, by that time, you can expect the swelling should start to go down. The pain should start to get better if you've had pain in the leg. And you should start to be able to get back to your normal activities, exercising, starting out with walking, and then just gradually increasing it and letting your body be the judge for what you can and cannot do. Pulmonary embolism, if you're still having shortness of breath and that, there are sequelae that can happen after you've had a clot. You can develop post-thrombotic syndrome if you have had a big clot in your leg, where you have, long-term problems with that leg. So if the swelling isn't getting any better and the pain isn't getting any better, make sure you get back in to see your doctor. The compression hose can help some. Some patients, yes, some patients, no. But with the pulmonary embolism, you want to, get in and make sure, if you've not had an echocardiogram, have that done to make sure that it hasn't caused any strain on the right side of your heart. Because that, if you're having a lot of shortness of breath and some swelling in that, you may have some problems with the right ventricle after a pulmonary embolism.
Okay, so in those first 30 days, I see where some patients are confused, because some doctors are saying you can start walking, that first week or the first couple of days, get circulation going. And some doctors are saying, no, don't do that for
No,
a month. What do
no,
you say?
absolutely. Walk.
Walk.
Walk. immobility is the worst thing you can do after a deep vein thrombosis. So you want to
Mhm.
keep the circulation going. You want to keep the blood, the clotting factors from pooling in your legs, and you want to make sure that you're having good circulation of the proteins that are going to dissolve that clot. So, and there, I can't think of a time when I've ever told a patient that they couldn't walk, or and start out, right away. We do not put patients on bed rest with DVTs or
Right.
PEP.
Yeah. Yeah. I was told to go home and walk the dog. It was right after my diagnosis, and I'm glad, and that helped keep down the swelling too.
Yeah.
So let's move into the second part of what I wanted to ask you. I want to talk to you specifically about risk factors. Let's talk about things like smoking, obesity, immobility, which you mentioned, certain medical conditions, and that history of blood clots, which we also talked about. Why do these matter, and how can people reduce their risk?
So some are modifiable, like obesity is modifiable. Smoking is modifiable. So both of those increase the inflammatory marker and inflammation. And inflammation is one of the reasons for people to form blood clots. Inflammation inside the body triggers clotting cascade to form blood clots. So if you can walk and lose weight, you're going to decrease your risk. If you can stop smoking, that's going to help you decrease the risk of another clot, plus other disease states that could lead you to be hypercoagulable, like lung cancer. So for the non-modifiable ones, there's certain genes you can't modify. So there's nothing you can do if you have a genetic mutation, factor V prothrombin gene mutation. There's nothing you can do other than take your anticoagulation and your exercise and smart choices. Um, have your regular screenings for your cancer, because cancer is probably one of the biggest presentations for patients that have unprovoked clot for us. Patients, especially if they present with bilateral clots in their legs, I always want to make sure that they've had their colorectal screening, their mammography, that they've had their pap smears and that, because it is a prothrombotic state. So you definitely want to make sure you stay up to date on your cancer screening.
Yeah, I think it's prostate cancer month. So I've been reminding guys to get their PSA, make sure they visit with a urologist. What was I? Oh, when you were talking about weight loss, I remember I lost 80 pounds because I knew I was overweight, but it took a combination, right? It took not just me picking up my activity level, but I had to watch what I was putting in my mouth. And that, to me, that made the biggest difference, was a nutrition change. You
Right.
stop pounding down the processed sugar and all that crap from the drive-through. Some of those pounds can be. I felt so much better once I did lose the weight, but yeah, the risk factors modifiable. We got to take control of that. So thank you for that answer, Leslie.
You made an interesting comment about inflammation. And you're suspect of, if you see the bilateral in the legs, that it could be cancer. Does inflammation impact provoked and unprovoked as well?
I would say yes, because I mean, you're the provoked, if you're in a bed and you have inflammation because you're overweight or morbidly obese, um, that would be a provoked clot.
Okay.
I mean, there's a reason. Unprovoked, I don't know. I guess because then are you saying, because you've got the risk factor, so it's kind of like it was, what came first, the chicken or the egg? Did you
Right.
form the clot because you're obese, or are you having a lot of inflammation? So I would say more so with the provoked. The unprovoked, backwards. I would say with the unprovoked, yes. With the provoked, you probably have more of a reason with it being one of the surgery, trauma, those kinds of things. So I don't think there's been any studies looking to see what the impact of obesity is, um, if it's more with the provoked or unprovoked.
It'd be interesting if somebody could actually do that analysis. Let's talk about what to expect after your diagnosis again. So, we always say, go talk to your own clinician. We're here for educational input, because recovery is different for everybody. And so I remember when I was first diagnosed and I got into one of the groups and somebody was talking about how they were running, a marathon. And I was like, oh my God, I'm like the biggest loser ever because like I can hardly walk down the hallway of my apartment. And so it was frustrating for me. Um, What's typical, if there is a typical, and we talked about 0 to 30. So what is it like for 0 to 30? What is it like from 30 to 90? And then 90 days post, do the majority of people actually get back to normal physically, emotionally, medically?
So I think it's going to be an individual. I would say that the majority of people, day 0 to 30, there's a big anxiety component there. It's like, why is this happening to me? What did I do? What did I do to deserve this? Is this going to kill me? Am I going to be able to do the things that I normally like to do? And there are some people that have had to change careers and things like that. You can't be a jockey if you have had a big blood clot, because I mean the chances of you having trauma or getting hit or those kinds of things. So I'd say 0 to 30, it's expected to be anxious. You're expected to have some discomfort and getting used to you're going to be on a new medication. You're going to be looking for signs of bleeding, which you didn't have to do before. But by day 30, people are kind of falling into the routine. And from 30 to 90, things start to get better for the majority of the people. Um, you don't notice the swelling in your leg. The shortness of breath has gotten better because the clot has dissolved in your lungs. But for some people, it doesn't get better. And I mean, and I don't want to be Debbie Downer, but the bottom line is that some people that have blood clots don't get better. And that really sucks. It really does, because it changes their life.
Mm-hmm.
And but that's where you want to get in with a good academic center, especially for those that have had a big pulmonary embolism. Uh, you can develop what's called CTEPH, but that can be treated. But it has to be identified. So people that have had a lot of clots that go to their lung, that's what CTEPH, it's chronic thromboembolic pulmonary hypertension it forms. But there's things that they can do for it now that weren't out there 20 years ago when I started doing this. So day 30 to 90, it's going to be too early to tell that. But after 90 days, if someone who's had a big pulmonary embolism comes back in and their echo's still not looking good, the RV's still down, then we're thinking we need to send them to the pulmonary specialists. And there's at all the academic centers, there's pulmonary specialists and pulmonary hypertension that can help you. Um, by day 90, I'd say everybody's back to their normal exercise activity if they've recovered. And then it's, how long am I going to stay on this? Am I on this for the rest of my life? So typically, my goal was usually 6 months for someone to reevaluate at 6 months and see how they're doing. Um, are they having any bleeding problems? Are they having problems with the copays? Because that's a big deal,
Mm-hmm.
um, especially for the elderly, because they're not able now. And I'm not sure what's going on with patient assistance any longer, if they're doing the copay cards, because Xarelto has come off patent, and I think Apixaban has too. So I don't know if they're supplementing the copays, and you could probably educate me better than I can, because you know what you are paying now with your insurance. But those are things that have to be taken into account. But I will tell you, I stopped very few people on their anticoagulants. I would lower their dose down to the 10 milligrams on the Xarelto and go to the 2.5 on the Apixaban at the 6 month mark if they did not have any major risks. For those that wanted to come off, I always offered them to check a D-dimer before they stopped, and then a D-dimer a month after they're off, just to make sure that they weren't gearing up. So that's just me clinically. There's no evidence to support that, but I trained under a thrombosis guru, and he had it was called, he had 4 tests that we did to look to see if people were clotting. more comfortable with just doing the D-dimer. It's not expensive, and that at least gives us an idea of where you were when you were anticoagulated, how much work was protein C and protein S doing while you were on your anticoagulant, and then how much is your D-dimer when you're not on anticoagulants. And so, but then I would also tell the patients if they wanted to come off to make sure around times of surgery or, medical illness where you're in bed for a long time, or if you're going to get pregnant after you stop, to always let your providers know because they may need to do a more aggressive prophylaxis or even put you back on treatment.
That's a really great suggestion. And also for folks that, you know, do want to come off to have that ability to have the D-dimer done and every so often and get tested. Once hopefully life returns to normal for the patient, whether or not they're on an anticoagulant or not, how often should they have follow-up? Is it once a year? Is it if you're provoked every, you say goodbye, or if you're unprovoked, you go once a year to the doctor? Like, what do you recommend for
I
people?
would say minimum of once a year for anybody, though, whether you've had a clot or not. You need to have a quarterback because we never know what's right around the corner. So, how hard is it to get into a primary care doctor nowadays if you
Mm,
don't have one? So, your primary care doctor is all you have to see, unless you've had a really complex clot or you have a complex thrombophilia, then you would be seeing a hematologist. And most hematologists, I would say, during the first 2 years is probably every 6 months and then annually after if things have quieted down.
okay, that's great advice. Todd?
Let's go ahead and shift to daily life. I'm going to throw you a couple questions at a time here. Being on a blood thinner slash anticoagulant, it can raise some questions about lifestyle. So let's focus on food real quick. Are there foods people should avoid or be careful with while they're on their anticoagulant? And why do some anticoagulants like Xarelto need to be taken with food?
Okay, so warfarin is the only one that you have to really worry about the food with, and that's just being consistent with your vitamin K intake. And the one thing that we always kind of warn patients about was not going overboard with grapefruit, or just being really, really consistent and diligent with that. So, warfarin interacts with over 400 medications as well. So, whenever you're started on a new medication, you want to make sure you contact your prescriber for your anticoagulant to see if you need to have a dose adjustment or have your INR checked more often. With the DOACs, I've not come across any foods that really impede that. Xarelto needs to be taken with food because the bioavailability is much higher if you take it with a meal as opposed to on an empty stomach. So you want to have the most efficacy of the drug. So in order for you to get to that 99% mark, you need to take it with food. And it should be not just a snack. You want to take it with a meal.
Both
Activity,
dosage?
huh?
Both dosage? With
Xarelto.
Xarelto, 20?
Only the 10 milligram does not, the 15 and the
Okay,
20. So when you go down to the 10 milligram dose, if you go on to the reduced dose, you don't need to take it with food. Only
okay.
the 15 and the 20 need to be taken with food. The Did you ask about activity?
Well, yeah, I was going to get to that, but let me ask you this one first. Is there medicine you cannot take when you're on an anticoagulant? What about NSAIDs? And what about herbal supplements?
Herbals are very tricky, especially with warfarin. So again, before you take any oral medications or supplements, check with your anticoagulation provider, or you can Google them now because when I first started doing this, we didn't have Google, but you can Google and see if it interacts with it. Um, the uh, the DOACs, when they first came out, there were some of the antiviral drugs that were not using so much anymore for HIV, a lot of the HIV, and then, uh, but those drugs are not widely used any longer. The newer HIV drugs are fine to take with the DOACs.
Okay. What about
Steroidal
alcohol?
Wait, I want to back up on
Okay.
nonsteroidals. That includes aspirin. Those all increase your risk for bleeding no matter which anticoagulant you're on. How they work is they knock the prostaglandins out in your stomach, which protects your stomach from acid. So when you knock those down and you take and you have an anticoagulant, if you have any predisposition to ulcers, you're going to have some bleeding from that. Alcohol, wouldn't we all love some? Uh, Alcohol in moderation is probably safe for all of them. It can affect the INR, and it can affect your ability to walk and talk rationally. So you don't want to take a lot of alcohol when you have anticoagulations on board, because if you take too much alcohol, you may fall down and you could hit your head. And if you hit your head, you can bleed into your head, and there's not a lot we can do in a short amount of time without taking you to surgery. That's why when you mention activity, it's important that when you're on anticoagulants, if you're riding a bike, you want to wear a helmet. Just do smart, stay smart, be safe, wear protective gear, skateboarding, wear your pads and things like that, because you can bleed into the joints if you crash on your bike or that. So just wear whatever protective garments you can to prevent trauma.
Yeah, it doesn't mean don't do that activity. It just means be smart about it. I wear, abdominal gear, shoulder pads when I'm mountain biking, but you just have to use some common sense and you can still enjoy a lot of those activities. Now, boxing and kickboxing, stuff like that, those are repeated hits. How do you feel about those activities?
I would say a strong no.
Okay. I knew you would. That was one of the questions that I saw in the Q&A because
Skydiving. Uh,
I
yeah,
skydive. I skydive.
yeah. I would not encourage skydiving,
Oh,
motorcycle racing, car racing,
skydiving's safer than mountain biking,
perhaps.
statistically.
All right.
That's because not as many people do it.
Exactly. We can debate this after the fact. Um, good common sense is what you want to use. Good
Right.
common sense. Okay. Let's talk about pregnancy, because we have had some folks say, I had a blood clot. I'm now not going to be able to ever get pregnant. What do you say to those folks? Can you get pregnant after a blood clot?
Absolutely. I told the patient one time that came into the anticoagulation clinic that she cannot get pregnant after, when she was taking this medicine. So she took that literally and came back pregnant because she thought it was birth control.
Oh my God.
So no, you can get pregnant. You just have to have it planned out. And even, worst case scenario, you get pregnant and you haven't, and you didn't plan it. You want to get into your anticoagulation provider right away. We don't know what the tetragenic effect is on the fetus on the DOACs. It's not been studied, and it's not going to be studied. They're off patent. They're not studying it. But what we do know is there is an alternate. You would do low molecular weight heparin through the pregnancy is what you would do. Occasionally, I'll see some people do unfractionated heparin or Rixtra if it's someone that has antiphospholipid or that. So, but you can get pregnant. You just want to plan around it. The safest form of birth control is not the pill for you if you've had a blood clot. So IUDs have been used widely in women post clot and have been effective, and they do not increase your risk for having another DVT or PE. Condoms don't increase your risk at all for having another clot, but they're not as fail proof as what an IUD would be.
Mm-hmm.
So it is very reasonable to consider having a family, but you need to realize that being pregnant is a prothrombotic state. Your body is getting ready to pass a bowling ball out your hoo-ha, and you're going to bleed after that happens. So during that last trimester and the period after that is when you're at most risk for having another clot. So
Yeah.
during the third trimester and the fourth trimester, which is postpartum, really postpartum is higher risk than the third trimester because you've just had this massive blood, you've passed a placenta, you're bleeding, and the body has been getting ready. We check fibrinogen levels on women that have had clot to make sure that it's not getting too high. So you would want to, if you've had a bad clot, you'd want to coordinate with your hematologist and a high risk fetal maternal medicine provider that is specialized in high risk moms.
Okay. So the answer is you absolutely can get pregnant if you've had a blood clot. You cannot be on a DOAC if you're pregnant.
or
Yeah.
warfarin for that matter.
Warfarin.
Works a week 6 through 12, you can't be on warfarin. So we have had women on warfarin after week 12.
Okay. And then really you should have your team in place. Your OBGYN should be communicating with your hematologist during the course of your pregnancy.
Correct.
And very good advice for 3 months after postpartum, women are still at risk of a blood clot. It's one of the leading causes of maternal mortality
It is.
in this country are blood clots. Okay. All right. We have a lot of really great questions. I know, Todd, you wanted to kind of wrap things up, but I would love to jump into questions soon. So if you want to.
Yeah, we have a lot of Q&A questions. And so Diane, in closing this part out, as someone who's helped so many people through this journey, I mean, you've helped thousands. What's one message you'd share with those newly diagnosed today? What do you wish more patients knew?
I think the importance of being consistent with your lifestyle and taking your medications and prioritizing your health and making the wise choices. So oftentimes when we had warfarin patients, they would not come in for their INR because of X, Y, or Z, and then they would have a bleed or they'd have another event. So just taking it very seriously because this is your life, and the it can turn on a dime if you're not careful. So make sure you have that shared decision making conversation with your provider about what your wishes are and what your fears and concerns are. And if you don't get the answers that you're hoping for, or they don't answer you, period, there are other doctors out there.
Mm.
There are other providers out
Mhm.
there. So don't be afraid to irritate your primary care doctor because they're not specialists in anticoagulation.
Yeah.
They're the quarterback. So if you need to talk to someone that specializes in clots, then go see a specialist.
You know what's weird is before my blood clots, I really didn't take good care of myself. I wasn't health conscious. It was
Yeah.
after I started throwing blood clots that I became serious about my health, and I'm actually in better fitness and shape now than before the clots. It's kind of weird how that works sometimes.
Yeah.
But thank
It
you very much.
it doesn't need to control your life either. This does not have to control your life.
Right.
You can live a very long and productive life after DVT and PE. It's just
Yeah.
a matter of, being aware and sharing that information that you've had clot with anybody that's going to do a procedure, or if you have any major illness or that, just so they know that you've already declared yourself as a clotter.
Yep. Thank you. Thank you, Diane. Okay, Leslie, we have some questions to get to. You want to start off?
Yeah, sure. And I'm not sure if this is from the same person or not, but I thought it was a really interesting question. By the way, someone wants to know if I can walk down the hallway. The answer is yes. I was talking about after my blood clot. That was my exercise going down the hallway. um, Newly diagnosed and literally just got out of the hospital. How do we differentiate between anxiety or a symptom of blood clot while on medication? I literally haven't slept. DVT, popliteal, and PE. And I feel for this person because I lived this also.
Yeah, I remember I met you right after your clot.
Yes.
Um, so it's a tough bird. I mean, a couple things you can do. Um, if you don't have a pulse ox, get a pulse ox where you can see how fast your heart rate is and make sure that your oxygen level is above 92%. Um, do some slow, deep breathing to see if you can calm yourself down. Are you having a panic attack? Because I know people are afraid to go to sleep after they've had one.
Mhm.
And I think the only thing that really makes it better is time. As time goes on and you see that, okay, I'm still here. You wake, you open your eyes and you're like, okay, am I alive? Uh, but it's really, there's not a whole lot you can do. And if you're that anxious, you can talk to your provider and see if they can give you some medications that are non-habit forming that will help with the anxiety. If it's just to get you over the hump.
Yeah.
So,
Also speaking to, a therapist,
Right.
um, And
And
then,
then the groups too, joining a group like this,
yes,
or just talking to other people that have walked the walk and talked the talk, they can empathize with you because they've been there.
yeah, for sure. I mean, I thought a lot of these things were unique to me and they were not. Everybody else was experiencing it. And so it gave me a lot of comfort to know that other folks that were out there in these groups were experiencing the same thing. The other thing that really helped me, and I don't know if this will help anybody that's out there, but I tried to think about where I would be a year from now and not so much about where I was right now. And knowing that I wanted to get healthier and exercise more and eat better more and maybe not drink as much wine as I used to, those kind of things, but really think about where I was going to be a year from now versus what I was dealing with right now. And that helped me mentally too. But I think it's a great question, and I think it's something that so many folks deal with. So I appreciate the person who put this through. Todd?
Yeah, and to piggyback off the anxiety thing, since it's so huge, one of the questions was, and you were talking about, you mentioned habit forming. They can put you on something that's not habit forming. So if people need mother's little helper, if they need some anxiety medication, say they're on Eliquis, there are some anti-anxiety meds that they can go on safely, correct?
Yes.
Okay.
Things like Lexapro is usually my go-to.
Okay, great. Thank you. Leslie?
Oh gosh, there's like so many questions here. Been diagnosed with unprovoked multiple PE. Does the number matter? No actual diagnosis of DVT, but assumed. Um, is that necessary? So
So I don't know if is it multiple episodes or there were multiple PEs in the lungs at the same time.
I think
Because
it's
what can
multiple.
happen is you can have a shower where a clot may break off from the leg and it goes up into the bronchial tree and it just fans out into multiple lobes.
Yeah.
Um, there's not, I mean, if they've tested and there's no, even if they found a thrombophilia, it depends on, you wouldn't be coming off if you were my patient. You'd be staying on anticoagulants indefinitely unless there was a contraindication, which would be bleeding typically. So, yeah, I don't think the number matters. I think the clot burden is probably more important to know. If you have a large clot burden, then the risk of you having heart involvement is much higher.
Hmm. Okay. Thank you.
Someone's asking about dental work. I'm on 2.5 milligrams 2 times a day. What do I need to be aware of if I need to go to the dentist?
Typically, with the DOACs, we do not hold them when you go to the dentist. Unless you're having more than 3 teeth extracted, then you would want to talk to your anticoagulation provider. But typically, the dental, we don't hold it.
Okay. Leslie?
Okay. How do people distinguish between sorry, wrong one. I have an occlusive clot in my superficial femoral vein. It runs the length of my thigh. I have no clots in my other leg. I suffered a severe leg injury 20 months ago. The trauma is ongoing. I need a total knee replacement, but that is now off the table, the doctors have told me. Is that really off the table for this person?
How long ago was the clot? 20 months
20
ago?
months ago.
I would check at an academic center. And I would need to, does it say if the clot's in the same leg, she needs the knee replacement?
Does not say.
Yeah.
I have no clots in my other leg, but suffered a severe leg injury 20 months ago.
And she needs an, I'm assuming it's probably the same leg. The clot has endothelialized by now. It's stable. Um, did they ever go in and try and do a thrombectomy and take it out? That's a big section of clots. So there are things that they can do to try and, if you have massive clot, they can go in and uh, retrieve those clots.
So
Um,
let me,
only typically if it's, if the limb is at risk. So it's not standards of care, but there are things that can be done for massive clot. I wanted to back up though. I saw a question pop up about colonoscopy because after the dental one. So colonoscopy is a little bit trickier. So a lot of the GI guys are doing the colonoscopies on full therapy, but they won't do any snaring of polyps or anything like that. So that might mean you have to go back and do the prep again. So I always talk to the patient and say, do you want to come off your anticoagulation and go on shots for a period of time if they're really high risk? Or do you want to stay on and then have to do the colonoscopy again if they have to do a biopsy?
Mhm. Coming back to the replacement here for a second. So dealing with orthopedic doctors, you're getting knee replacement, you're getting hip replacement. You've already had a clot. So you have, some risk factors, and you have some risk factors coming up because of the orthopedic surgery that you're going to be having. Orthopedics love to give aspirin after you have hip and knee, right? And so what should the recommendation be? What should that conversation be?
I don't think you're going to see an orthopedic giving someone aspirin after their joint replacement if they've already had a clot.
Okay.
They tend to use the DOACs routinely, or low molecular weight heparin. For that person that needs, if it's you have that shared decision making conversation, if this is life altering for you, you want that knee, you go on a parental, go on Lovenox for 4 or 5 days post-op, and then start on back on your DOAC. But I would definitely check with an academic center if you're not there already.
Okay, good advice. And I saw that we put in the chat some information about orthopedic surgery and blood clots. So if you're contemplating or going to be having it, please read that beforehand. Okay, Todd?
Diane, so you'd mentioned you talked a little bit about being adherent with the medication, but you know what? Life happens. Sometimes people miss a dose. So a question that came in was, if someone on a twice a day per day DOAC misses a dose, what would be their best course of action?
So if you haven't gone to bed, take it. The next day, don't double up, just get back on your regimen. If you've only missed one, try not to do that routinely because you're not going to be protected then. So take it, if it's the same day, I would say take it, if normally you take it at like 7 and 7, and then you're going to bed and you're like, oh my gosh, I forgot my dose. Take it at bedtime, and then just get back on your 7 and 7 dose
Okay.
the next day.
Okay, Leslie?
Ugh, there's so many awesome questions I wish we could get. We have like 300 of them, which we're not going to do tonight. Don't worry. But there's just so many great. How long will it take for my lungs to feel normal again after my PE?
No idea. I really don't. It just really depends on the individual and what other comorbidities they have, how big their clot was. I would say the average person within about 4 to 6 weeks is back to baseline,
Mhm.
and you may have a new baseline.
Okay.
How long does it usually take for a clot to resolve while you're on an anticoagulant? But more importantly, this question that came in was, what happens if it doesn't resolve? What happens if it doesn't absorb? What happens then?
So that you will endothelialize, you'll form, say, skin around it inside the vessel, and it stabilizes it. Not all clot do go away. You'll have some people will have residual clot. The imaging now has gotten pretty sophisticated where we can differentiate old clot from new clot. So you can tell if the clot's propagated and gotten bigger, or is this still the same old clot that you had last year. And there's not a good timetable. That it just really depends on how big the clot was, and it really depends on the patient's cystic clotting cascade. Are they adequate protein C, protein S? That do they have the proteins they need to dissolve the clot?
Okay. Leslie?
Um, do you recommend compression socks, and can you use compression socks that have zippers, which I didn't even know that was a thing?
You can. So for the morbidly obese patient, you can't get the compression socks that are online now. So oftentimes they have to have custom made ones, or they just they're really hard to get on. The studies were done with the 20 to 30 millimeters of pressure, and that's pretty tight.
Hmm.
I've seen some with 30 to 40, but they do help with the swelling. They help your legs feel better, and they do increase the circulation back to your heart. We are not talking TED hose that they use in the hospital. I don't even know if they use those in the hospital anymore. But compression stockings have more elastic in them, so they do return the circulation. So yeah, I do recommend them.
Okay, great. And also we have an annual PEP in July where we bring in Dr. Wasan, who's on our medical and scientific advisory board with you, and she speaks about compression. So if anybody's interested in compression, we'll put that into the chat also so they can access that that PEP. Todd, I'm going to suggest you take the last question. I'm assuming that we've had Diane here now with us for an hour and a half. So
Yeah, and this comes into the group all the time. This is a question that was asked in the Q&A. Do you think drinking pineapple juice, eating ginger, and I'm going to throw in turmeric and all this other stuff and garlic, is that going to help you prevent future blood clots?
I will say I have no idea. I don't. I've never heard it. I've never seen any literature to support it. It's not going to hurt you to do it. It's not going to affect your, it's not going to cause you to have more clot.
Right, right.
So if that's something you want to do and you feel like it's safe, but I don't know where it's coming from.
I think some people are worried about using this stuff and being on an anticoagulant because it may increase the bleeding.
No.
And no, yeah,
right.
moderation is the magic word to me. I eat all that stuff.
Yeah.
We're not going to end on that question, so I'm taking the last one here.
Here we go.
What are acceptable SpO2 fluctuations post-diagnosis?
You weren't
should the
listening. I
range?
said it needs to be above 92%.
Yes.
So, and I'll caveat that with, unless you have COPD, then it needs to be above 88%. So 92% is the cutoff. And normal people, I would say, is 95 to 99 to 100. But a normal, if you have someone that has had a PE, they've been monitored. Very few people don't get admitted to the hospital, or at least to an observation unit. So you'll know what your pulse oximeter is. So if it drops, so if you're 97 or 98% and you're more short of breath and you're at home and now you're 92 or 93%, that's something you should call your doctor and say, hey, I was 98% when I was in the hospital and I wasn't on oxygen, and now I'm 93% and I'm short of breath. So let that guide you. But if you drop below 92%, then I would say go to the emergency room.
Okay, good advice. Thank you. All right. I don't know if do we have post questions?
I think we only have two.
I mean, I learned so much tonight. I learned so much from you every time you come on. Thank you for just being this incredible wealth of knowledge and for your willingness to share it with all of us.